Hello, let me give some overview about this video. We can divide abnormal uterine bleeding as premenopausal causes and postmenopausal causes. But this video is about abnormal uterine bleeding of premenopausal women. I will deal with postmenopausal causes in another video. So I will tell you initially what are the types of abnormal uterine bleeding and differential diagnosis for them. Then I will classify abnormal uterine bleeding according to the famous COEIN mnemonic, structural and non-structural causes. Then I will go through special points in history, examination and management. Before going into abnormal, let's see what is normal. To say as it's normal menstrual bleeding, it should be regular and within 24 days to 35 days cycle, but can't be irregular within those. First it will be 24 days, next 33 days, next 28 days. It's irregular. The menstruation should be last between 3 to 7 days. There should be no clots and the amount should be less than 8 milliliters. Anything abnormal from normal menstruation, we can call it as an abnormal uterine bleeding in premenopausal women. This abnormality may have different characteristics like frequency, increased or decreased. It's mainly due to hypothalamo-pituitary ovarian axis dysfunction. Then the blood loss. The differential diagnosis for heavy menstrual bleeding are fibroids, adenomyosis, hypothyroidism, bleeding disorders. Then the duration may be abnormal. Prolonged menstrual bleeding. The differential diagnoses are fibroid, adenomyosis, hypothyroidism, and bleeding disorders. So then the abnormality may be due to irregularity. That irregularity may be related to menstruation or not related to menstruation. Previously I told about menstrual irregularity. Now I'm going to talk about non-menstrual things. So it may be due to intermenstrual bleeding or differential diagnosis of cervical or endometrial polyp carcinoma, and postcoital bleeding may be due to cervical or vaginal polyp or carcinoma. So it's just an introduction. Now let's go to the proper one. Every gynae student must know the famous mnemonic COEIN for abnormal uterine bleeding. That mnemonic represents the causes of abnormal uterine bleeding. PALM stands for structural causes and COEIN for non-structural causes. First, let's talk about structural or PALM group. P is for polyp. In the history, patient may complain of heavy menstrual bleeding, irregular bleeding, postcoital bleeding, intermenstrual bleeding, and vaginal discharge. On speculum examination, you will see a polyp coming through cervical os if it is endometrial in origin. And if you see a polyp coming from os, it is a cervical polyp. So you can diagnose this from transvaginal scan, and the treatment option is hysteroscopy and resection. Next one of PALM group, A for adenomyosis. This usually occurs in multipara. They will complain of regular heavy menstrual bleeding, pain confined to periods, and on and off dyspareunia. This occurs due to the endometrial tissues going into the myometrium. So the surface area is increased, causing heavy menstrual bleeding. On examination, you will see a suprapubic tenderness. On bimanual vaginal examination, the uterus size will be around 8 weeks. It will be mobile, tender, and uniformly enlarged. On evaluating these patients, you should evaluate endometrium also, because there may be other endometrial pathologies. So if patient is anemic, you have to treat it. NSAIDs and antifibrinolytic to reduce amount and the reduced duration of menstruation, such as mefenamic acid and tranexamic acid for symptomatic treatment. You can also get hormonal treatment like combined oral contraceptive pills, progesterone preparations like notestosterone, DMP injections, and levonorgestrel containing intrauterine systems. If medical management fails or the patient has no fertility issues, you can go into hysterectomy. It is the definitive treatment for adenomyosis. Next one is L, leiomyoma, or commonly known as fibroid. Patient may be present with menstrual symptoms, abdominal distension, pregnant-related symptoms, pressure symptoms, and with complications. So what are the menstrual-related symptoms? It may be heavy menstrual bleeding, mainly due to submucosal fibroids. It can be regular or irregular. Then there will be pregnancy-related symptoms like subfertility, miscarriages, previous baby malpresentations, postpartum hemorrhages, dysfunctional labor, and baby may be non-engaged at term. You should ask past obstetric history for that. There may be pressure symptoms. If a large fibroid is on anterior wall, there may be increased urinary frequency, difficulty in passing urine, and urine retention. If a large fibroid is on posterior wall, it may cause bowel symptoms like constipation. And there may be other pressure symptoms like edema and varicose veins. The complications will be the red degeneration. There is a sudden severe localized abdominal pain. There may be anemia because of heavy menstrual bleeding. So on examination, you should look for the features of anemia. On abdominal examination, the abdominal may be distended. You will feel a lump which is pelvic in origin. You may not be able to go below the mass. The mobility will be restricted in vertical pain. On bimanual examination, you should say whether you can feel the mass you palpate in abdomen or not. So also you have to say how many weeks in size. To confirm a leiomyoma, you can do ultrasound scan. If she is asymptomatic and can wait, we can do watchful waiting. Can repeat the ultrasound scan within 6 to 12 months. If she is symptomatic, there are two options, either medical treatment or surgical treatment. So until you get a date for surgery, you can do medical treatment. To heavy menstrual bleedings, you can give mefenamic acid, tranexamic acid, and progesterone preparations like noethestron. To reduce the size of the fibroid, you can use GnRH analogs and danazole. Next is the surgical options. If main concern is subfertility, can offer myomectomy. However, the definitive treatment, if she has no fertility issues and if she has completed her family, is hysterectomy. Then here we comes to the last letter of PALM, M. M is for malignancy, either cervical malignancy or endometrial malignancy. First, I'm going to cervical malignancies. The history may tell you about postcoital bleeding, pelvic pain, vaginal discharges. Also, you can ask for risk factors like smoking, sexually transmitted infections, high-risk sexual partners. On speculum examination, you can see unhealthy cervix. If there's no visible lesion, you can take a cervical smear OB. If there is a visible lesion, you can take a biopsy. Write that a request form has urgent histology. Cervical smear comes as inflammatory, it's cervicitis, so we can treat for it. If it comes as low grade squamous intraepithelial lesion, we can repeat it in 6 months. If the 6-month reports come as LCL, we should do a colposcopy and biopsy. If smear result came as high grade squamous intraepithelial lesion, we have to do colposcopy and biopsy. Next possibility of cervical smear is abdominal glandular cell. Then we have to do both colposcopy and biopsy and endometrial sampling. Until the histology result arrive, you should do ultrasound scan to assess the vascularity, the complications like hydronephrosis, hydroureter. You can do CT scan of chest, abdomen, and pelvis to see secondaries, the lesion extension, the exact size of the lesion, lymph node involvement. But if you work in a peripheral hospital where ultrasound scan and CT scan facilities are not available, you can always do a chest X-ray and ECG and send the patient. Now, the histology report came as a cervical carcinoma. Here we do a clinical staging. It is FIGO classification, but I'm not going to mention each and every stage here. For the management, I will divide these stages into two. First one is lesion less than 4 centimeters, which is confined to cervix. It includes 1A1, 1A2, 1B1 stages. So we can offer surgery for these stages according to the fertility wish. If she wishes for fertility, we can offer radical trachelectomy, and if there is no fertility wish, we can do radical hysterectomy. From 1B and above, the option is chemotherapy. So next malignancy I'm going to talk under M of palm is endometrial carcinoma, but I will deal this topic extensively in post-menopausal bleeding video. I'll just touch topic in here. They may come with irregular menstrual bleeding and intramenstrual bleeding. May also have symptoms of bladder and bowel involvement like hematuria. On examination, uterus may not be palpable most of the time. Next, you are going to do endometrial sampling. COEIN group, the non-structural causes for abnormal uterine bleeding. C is for coagulopathy, like von Willebrand factor disease. Second cause in COEIN is ovulatory dysfunction. It may be physiological or pathological. Physiological occurs in extremes of reproductive age, like close to menopause and close to menarche. Suppose 18 years old girl comes with irregular menstrual bleeding, what will you do? So this is mostly physiological now, so you have to counsel her regarding that. And if there's pain, you can offer painkillers like NSAIDs, and you can offer oral contraceptive pills. It may reduce the bleeding and regulate her cycles. Let's go into pathological cause of ovulatory dysfunction. The first one, polycystic ovarian syndrome, or some says polycystic ovarian disease. We diagnose it using Rotterdam consensus criteria. There are three: the ultrasound evidence of polycystic ovaries, oligo or anovulation, and clinical or biochemical evidence of hyperandrogenism. Also, other investigations may show elevated LH levels, elevated LH to FSH ratio, increased fasting insulin levels, elevated testosterone levels because sex hormone binding globulins are low. Most women present with PCOS are the women between 20 years and 30 years. I would like to say the symptom and next the management. Regular calorie burning exercises and diet control are the first line treatments for obese patients with PCOS. They will present with irregular menstrual cycles, usually the amenorrhea followed by heavy menstrual bleeding. So we can offer combined oral contraceptive pills. We can offer cyclical noetestrone for them. They will present with the symptoms of androgen excess like acne, hirsutism, male pattern hair loss, but there's no virilism. Hirsutism is reversible. To that, we can offer a COCP and also cyproterone acetate. After that, those who are suffering with subfertility can introduce ovulation induction. We can use either clomiphene citrate, which is an anti-estrogenic drug, or letrozole, which is an aromatase inhibitor. Also, we can do laparoscopic diathermic cauterization of follicles. These patients also have metabolic problems, so we have to investigate. They might be doing fasting blood sugar to assess the insulin resistance, whether she has type 2 diabetes mellitus, and we can do serum cholesterol and lipid profile. Then let's see the other causes of ovulatory dysfunction. One is hypothyroidism. You should do thyroid function test if you suspect it. Next one is hyperprolactinemia, headache, galactorrhea, bitemporal hemianopia are the symptoms. Other causes of ovulatory dysfunction are mental stress, obesity, weight loss, anorexia, and excessive exercises. Then we go to third letter, E of COEIN, endometrial disorders. This is considered after excluding all other causes. This may be due to arteriovenous malformation, some abnormality in production of vasodilators and vasoconstrictors. Next one is I for iatrogenic causes. It means some medications are causing abnormal uterine bleeding, such as combined oral contraceptive pills, injectable progesterone implants, levonorgestrel containing intrauterine devices. They can cause amenorrhea, breakthrough bleeding, irregular bleeding. Then the copper containing intrauterine devices can cause excessive bleeding plus or minus irregular bleeding. Then the drugs like antiplatelets, aspirin, clopid, drugs like warfarin, which are anticoagulant. The next one, N, is for not yet classified causes. So we completed the COEIN part. So one last thing is left. It is postmenopausal bleeding. It will be the next topic of this series.